Respected chairpersons and learned audience, Assalamu alaikum. It's my great pleasure, and I'm very much honored to be present my cases in front of such eminent cardiologists. Today, I'm going to present a couple of cases where we unlock the puzzle. Actually, this is my first case, Mrs. X, 37 years old lawyer, who was non-diabetic, normotensive, had a history of sudden weakness of the left side of the body, along with speech difficulty for 5 days. Vitals were within normal limit. Cardiovascular system examination was unremarkable, but the neurological examination showed there is upper motor neuron lesion features in the left side. And patient was clinically diagnosed as acute stroke with left-sided hemiparesis. An MRI showed there is ischemic stroke in the frontoparietal region. ECG was normal, and with this, patient was admitted in a ICU of a private hospital and managed conservatively. On the 6th day of admission, patient developed sudden swelling of her right leg, and a duplex study confirms that there is DVT in the right leg, and patient was started initially low molecular heparin followed by warfarin. An echocardiogram was done there, which was marked as normal, and 48 hours Holter monitoring was unremarkable. So at this point, patient was referred to NSABD for extensive cardiovascular evaluation, whether there is any causal relationship of the stroke with the cardiac shunts. So at this point, what should we do next? We plan to go for thrombophilia screening, which showed there is reduced level of protein C and protein S. And as you all know, as this patient is getting warfarin, so warfarin may contribute to the reduction of this protein C and protein S level. And other factors like antithrombin 3 and factor 5 Leiden was normal. INR level was 3.67, and the ANA, anti-TS DNA, antiphospholipid antibody, and ENA profile were negative. So at this point, we did an echocardiogram, which showed that there is actually, we failed to prove any intracardiac shunt. But at this point, I have to go through the books, and which showed the American Association of Neurology guideline to 2020 suggested that all patients of this high risk of cardiac source of stroke should be evaluated by transesophageal echo. And if both the initial tests are negative, then we have to go for bubble contrast test with or without Valsalva maneuver. So at rest, when we did the bubble contrast, there is no bubbles passed from right side to the left side. But when we did the Valsalva maneuver with the passive method, as the patient was not so compliant, so when we pressed the abdomen, then a bunch of microbubbles passed from the right side to the left side, which is very much suggestive of presence of PFO. So regarding bubble test, when it signifies that there is intracardiac shunt, it signifies when at least 3 bubbles passed from right side to the left side within 3 cardiac beats. So our final diagnosis was non-lacunar cryptogenic ischemic stroke with PFO with DVT. So at this point, the question is that, is PFO causing the stroke or it's an innocent bystander? Regarding this, Rope score and Pascal score helped us. When the Rope score is high, it is very much suggestive of that the stroke is caused by PFO. And when the Pascal high Rope score is associated with the high-risk PFO features like atrial septal aneurysm or large shunt PFO, it is probable that stroke is caused by PFO. Now, another question is that, does PFO closure reduce the risk of stroke? In 2018, meta-analysis from the 4 trials and 2021 meta-analysis from the 6 RCTs showed that PFO closure reduced the risk of recurrent stroke, as well as the annual incidence of the stroke is reduced compared to the medical therapy alone. So, on the basis of that, 2021, the secondary stroke prevention guidelines suggest PFO closure is reasonable in the age when the patient's age is in between 18 to 60 years with a non-lacunar stroke, no other identifiable cause, and high risk of PFO. So we went through, so we plan to go for PFO device closure, and first we took a multi-purpose catheter from the right femoral root and crossed through it, and then the super stiff wire was placed in the RUPV, and a tin French sheath was crossed through the lesion PFO, and then we took 25 millimeter Seroflex PFO occluder. And finally, it was positioned and confirmed by the echocardiogram and then released, and device is in position. So we continued the warfarin for 3 months and plan to repeat the protein C and protein S level after stopping warfarin 3 months later. And my second case is Mr. Y, 23 years old student, presented to us with sudden development of loss of feeling of his right hand and arm. And he had no history of conventional risk factors for stroke, vitals normal, neurological and cardiovascular system was unremarkable. Echo, 48 hours Holter monitoring and thrombophilic screening were negative. And MRI showed a focus of subaqueous established infarct in the left parasternal gyrus. And transesophageal echo showed a slit-like opening, as well as there is a small left to right shunt. And when we did the bubble contrast at the rest, it showed a single bubble passed from the right to left. But when we did the bubble contrast at Valsalva, it showed a bunch of microbubbles passed through the right side from the left side. So we diagnosed it as before and go for the device closure, and which show and it was as before, so I'm not describing it. And we took 25 millimeter Amplazer PFO occluder, and it was released, and this is the final view.
Thank you, Dr. Adnan Bashar, for your nice, excellent, and elaborate presentation.
Thank you all. And